Good afternoon. Welcome to the webinar, What is ACL's Interest in HCBS Quality? Please remember to mute your phones and computers for the duration of the webinar. The link to access closed captioning is located in the chat feature. Please also use the chat feature to ask any technical questions if you are experiencing technical difficulty. I would now like to turn the conference over to Meredith Raymond. Thank you, ma'am. You may begin.
Good afternoon. Thank you for joining us for the kickoff of our home and community-based quality webinar series, What is ACL's Interest in HCBS Quality? This series will consist of informational webinars occurring on a bi-monthly basis to build awareness of ACL's commitment to and development of HCBS quality measures, and to provide a platform among internal and external stakeholders to share developments and collaborate on efforts concerning HCBS quality. To begin, today's webinar will provide a broad overview of ACL's HCBS quality initiatives. Due to a very full agenda, we will keep introductions short. First, we will have Edwin Walker, our Deputy Assistant Secretary for Aging, to provide welcoming remarks. Next, Susan Jenkins, the Director of the Office of Performance and Evaluation, will discuss an overview of quality measurement. Eliza Bangett, the Director of the Office of Policy Analysis and Development, will discuss our work with the National Quality Forum. Then Sean Terrell will discuss our contract work with the National Core Indicators and Survey Development. And lastly, Amanda Richard will present an overview of the Rehabilitation Research Training Center at the University of Minnesota and their studies on measurement development. If time allows, we will then have a Q&A period to answer the pre-selected question, how do you measure quality? Now I'd like to introduce Edwin Walker, our Deputy Assistant Secretary for Aging, to provide welcoming remarks.
Thank you so much, Meredith. And I'd like to welcome everyone to this webinar. Here at the Administration for Community Living, we have been working with our partners and other federal agencies, states, consumers and advocates, providers, and stakeholders to create a sustainable long-term services and support system where older adults and people with disabilities have choice, control, and access to a full array of quality services that assure optimal outcomes, including independence, good health, and quality of life. Advancing the identification, development, and implementation of measures of quality community living options that can be used by public and private entities is really central to our vision that all people, regardless of age and disability, live with dignity, make their own choices, and participate fully in society. The concept of measurement forces us to ask ourselves, what is the basis for our claims and how are we fulfilling our mission through this work? The development and implementation of national standards for high-quality long-term services and supports and the systems that provide them is needed to help track and measure the reach and effectiveness of national, state, and community programs. The Administration for Community Living is working to support the development of standards and measures directly related to the well-being of older adults, persons with disabilities, and their families, as well as the availability of and access to services and supports for all individuals in need of long-term services and supports. These standards are being developed and implemented through ongoing program performance, program evaluation, and other continual quality improvement strategies. Next, I'll address the need and efforts made toward home and community-based services quality measurement development. Home and community-based services are at the nexus of community living. More than 12 million Americans need long-term services and supports, a number that's expected to increase to 27 million by the year 2050. There have been a few efforts on the federal level to examine performance measurement and quality improvement for home and community-based services. In 2005, the Agency for Healthcare Research and Quality contracted with Truven Health Analytics to conduct an environmental scan of HCBS quality measures for the Medicaid program. In 2014, the CMS Testing Experience and Functional Tools, or TEFT planning grants led to the development of an HCBS Consumer Experience of Care survey used to construct performance measures related to beneficiaries' experience with Medicaid services and an electronic long-term services and supports service plan standard, or ELTSS, that can enable the electronic exchange of information relevant to the care of persons receiving HCBS. There have also been efforts at the state level. There are a growing use of surveys to assess HCBS quality, including the National Core Indicators, Money Follows the Person Quality of Life Survey, and Health Outcomes Survey used in the program of All-Inclusive Care for the Elderly, or PACE. Despite these efforts, the development, availability, and implementation of HCBS measures remain limited. Currently, there are many measures endorsed by the National Quality Forum, but very few are considered home and community-based services related. As we move toward value-based purchasing and increasingly integrate home and community-based services with medical services, it becomes more critical to capture the experience of people who use HCBS and work towards assuring that home and community-based services are of highest quality. At the Administration for Community Living, we strongly support any progress toward nationally validated outcome measures for long-term services and supports, and have invested in a number of initiatives which you will hear more about today and in future webinars that we're working on toward this goal. The National Quality Forum Group on Measuring HCBS Quality completed a 2-year effort to develop a conceptual framework for measurement, review existing literature for measurement guidance, identify gaps in measures, and made recommendations on HCBS measurement last fall. We also have supported the development and implementation of the National Core Indicators for Aging and Disability. These two related survey instruments continue to inform the field on state system performance. The National Institute on Disability, Independent Living, and Rehabilitation Research is funding a rehabilitation research and training center on home and community-based services outcomes. The result will be a set of recommended measures and procedures to ensure that they support quality of life outcomes for people with disabilities and older adults. The purpose of this informational webinar series is to increase awareness of ACL's commitment to and development of HCBS measures and to provide a platform among internal and external stakeholders to share developments and collaboration efforts in the HCBS quality field. The first 3 webinars in the series will focus on ACL initiatives. However, we welcome your suggestions for topics of future webinars. We need you to help us continue this work and look to you for input, assistance, and collaboration on all things HCBS quality. Thank you, and back to you now, Meredith.
Thank you, Edwin. Now I'd like to introduce Susan Jenkins to provide an overview of quality measurement.
Thank you, Meredith. Good afternoon, everyone. My name is Susan Jenkins, and I've been gathering information about how programs operate and whether they're providing quality services to individuals and communities for almost 25 years. I've seen firsthand how programs that have data to make decisions about what to fund, what initiatives to pursue, and what policies to implement, how much better they do when they have those data than programs that don't. And I'm happy to be able to share some of what I've learned with you today. Next slide. Why is quality measurement important? Program evaluation is a systematic method for collecting, analyzing, and using information to answer questions about projects, policies, and programs, particularly about the effectiveness and efficiency of those policies, programs, and projects. It's important to remember that when we think about measuring how our programs or services are performing, we have to look at quality and quality measurement. Quality measurement is a type of evaluation. The Institute of Medicine defines healthcare quality as the degree to which healthcare services for individuals and populations increase the likelihood of desired health outcomes and are consistent with current professional knowledge. With regard to home and community-based services and ACL's mission to maximize the independence, well-being, and health of older adults, people with disabilities, and their families and caregivers, we can expand that idea from clinical services to include supportive services and the degree to which those services impact the well-being of those that we serve. When thinking about program or service quality, we commonly think about 6 dimensions. The first is effectiveness, and that's related to providing services that achieve the desired outcome, which in this case is helping people to live independently with maximal health and well-being. Another is efficiency. Are we doing the most that we can with the resources that we have? We also have to be concerned with equity, which is related to providing services of equal quality to those who may differ in their personal characteristics. We also look at person-centeredness, which relates to meeting consumers' needs and preferences, safety, which is related to the actual or potential bodily harm, and finally, timeliness, which relates to obtaining the needing services, providing the needing services, or having access to the needed services as quickly as possible. And ACL examines these dimensions, but we have a particular focus on 3 and what we call a 3-legged stool approach, which helps us to make sure that we provide the best services possible and do not pull too far in one direction at the expense of other programmatic priorities. These 3 legs that we use to balance our measures to ensure the overall appropriateness of our services are targeting. We ask ourselves, are we serving the right people, those who are most needy and those who can most benefit from our services? Another is efficiency. Are we providing the services at a reasonable unit cost? And the other is quality. Are the services of a decent or acceptable quality? And to bring these ideas to life, imagine a meals program that's designed to help people to stay in the community and live independently. We could appear to be successful if we serve people at low risk for being institutionalized, because very few of those people would ultimately enter a care facility. But because they're at low risk for entering a care facility, it's unlikely that our meals are actually making the difference. So in that case, we're not really meeting our purpose of helping people at risk for entering a facility to remain independent in the community. We could also be very efficient and serve a lot of people if we serve very poor quality meals. Again, not meeting our mission of the program, because those meals may not be nutritious or the people may not eat them. So we have to look at quality of the meals in terms of consumer satisfaction and nutritional quality. It is only by balancing these 3 things that we can truly meet the mission of helping people to live independently. Next slide. I want to offer a little bit of history now and make the point that the move to quality is not new, even if it hasn't always been talked about using the terms that we use today. Enacted in 1993, GIPRA, which was the forerunner of the GIPRA Modernization Act, was designed to improve program management throughout the federal government. The GIPRA Modernization Act of 2010, then, was designed to keep the best parts of GIPRA, the Government Reports and Performance Act, while addressing some of its weaknesses. And the Modernization Act established important changes to the existing requirements that moved toward a more useful approach to performance planning and reporting. The Modernization Act also served as a foundation for helping agencies to focus on their highest priorities and create a culture where data and empirical evidence play a greater role in policy, budget, and management decisions. In other words, using data such as that about program and service quality to make programmatic and policy decisions that improve the programs and the services that we offer. Next slide. In 2013, the memorandum shown on this slide, M1317, offered approaches for strengthening agencies' ability to continually improve program performance by applying existing evidence about what works, generating new knowledge, and using experimentation and innovation to test new approaches to program delivery. In the HCBS context, this means finding out which policies, programs, and services are best at helping individuals and communities to make their own choices and to participate fully in society. Next slide. In the recent 2018 budget blueprint, the current administration also discusses the use of evidence and measurement of program quality. They talk about using real hard data to identify poorly performing programs and organizations, which we would say are of a lower quality, and identifying those that are of a very high quality and making decisions ostensibly based on those data. The next slide. So the question becomes, why should we measure? And there are many reasons, some of which were stated in the previous slides, but also if we don't examine our programs objectively, we cannot really know whether they are improving people's lives either directly through service provision or indirectly through improved efficiency in systems. Measurement of program quality can help us maintain high-quality programs and improve lower-performing programs. It can help us to give individuals and stakeholders information about program quality to help them choose what services and approaches are best for them, and to ensure that we are getting our money's worth by making sure that we are getting the level of quality that we expect. It is important to remember, though, that the measurement of quality is an improvement tool, not an end in itself. We should use quality measurement to tell us where we need to look more closely as we work to serve individuals and communities in the best, most effective ways possible. Next slide. And what to measure. And we can't measure everything. And even though I'm an evaluator and I focus on program measurement, I do realize that we shouldn't have measurement overcome the value of the program. And so there's a saying that we use sometimes in the evaluation field that if you can define it, we can measure it. But we need to remember that just because we can measure something or it's easy to measure something, that doesn't mean that we should. Measurement should complement the program and gather the most important information needed for decision-making and service improvement. Next slide. So as we try to think about what we would measure, we can think about some common areas for measurement. And there's several program dimensions that it makes the most sense to measure because these are things that we can have some control over as we try to improve our programs or maintain their quality. These include the quality of how care is structured. For example, is it holistic? Is it multidisciplinary? How the process of providing care affects consumers and their health outcomes and their community living outcomes, and what are the consumer outcomes in terms of health, well-being, and independence. We can also look at the level of resources used and compare the resources per positive outcome. So, for example, we may want to measure the cost per day remaining in the community, the cost per person who reports living in the setting that they want to live in, or the cost per satisfactory person-centered plan developed. Next slide. And when we think about what to measure, we also have to think about how to create those measures. And the basis of evaluation and performance measurement is comparing actual performance of your program, your service, your policy to its intended objectives. Sometimes those objectives are well-defined and clearly stated, but many times they are not, and many times they are not measurable as written. So once we have an idea about the service structure, the processes and cost, as well as the expected outcomes for systems and consumers, we can start to develop specific measures, the measures that explicitly define what will be collected. And ACL follows the SMART model to create easily understandable objectives of performance of quality. And so there are the 5 areas, and by specific we mean the description of the objective is well written in a way that anyone reading it can interpret it the same way. 2 different programs, 2 different providers have to be reporting comparable, similar data. They have to understand the objectives in the same way. And that ensures that an objective is specific so that to make sure that it's described in a way that's observable. And so by specific, we mean all of those things. By measurable, we mean the extent to which something can be evaluated against some standard. An objective with quality measurement would describe a requirement in terms of its accuracy, its format, its how well it fits within standard guidelines of service. By achievable, we ask the question, can the program, policy, or service make the desired difference? It also answers the question, can it be done given the time frame, opportunity, and resources available to us? By relevant, we refer back to the statement from the earlier slide that not everything that can be counted counts. We should measure the most important things over which we have control and which most contribute to our purpose, the most relevant items. And time-oriented means that we define an endpoint for the measurement so that we have a goal for when we expect to have met the objective or milestones towards that objective. Next slide. Another way to think about specific is by looking at the numerator and the denominator and defining them very clearly as shown on this slide. And what I mean is we define a numerator, which might be who or what system components showed the desired result. In this example, the number of people with a person-centered plan. which would then be divided by a denominator, which includes all of the relevant people or system components, those that if the program worked perfectly could have or should have had the positive result. In the denominator, we do not include people or service components that were not exposed to or eligible for the service. We want to look at the people that could have made the change that we're looking for divided by all of the people. We want to look at the people who made the change, the desired change that we're looking for, divided by all of those people that had the opportunity to make that change. And on the next slide, there's a funny way to highlight the importance of knowing our denominator. We have to know the context in which we're operating to really understand the quality of our programs. And in this case, if the little cat got 3 stars out of 3 stars, that's a much more positive outcome than what it really turns out to be, which is 3 stars out of 1,000,000 stars. And so to take it back to an example from the previous page, if we learn that 10,000 consumers now have person-centered plans, that's great. It's great if we know that there were 10,500 people eligible to develop such plans. That would be a rate of 95%. That would suggest that we have a quality program or approach for developing person-centered plans. It's not so great if our system includes 50,000 consumers, of which 10,000 is really only 20%. So thank you for all your attention as I discuss quality measurement, and thank you, Meredith.
Thank you, Susan. Now Eliza Bangett will discuss our work with the National Quality Forum.
Hi, good afternoon, everyone. I will provide an overview today of the work by the National Quality Forum, or NQF, on quality in home and community-based services to support community living. I'm only providing a brief overview today, so I invite all of you to tune in again on June 28th at the same time, 2 p.m. Our colleagues at the National Quality Forum will be providing a more in-depth presentation on this work, so please stay tuned for that. Moving on, next slide, please. Section 1890 of the Social Security Act requires the Secretary of Health and Human Services to identify a consensus-based entity, or CBE. Under this authority, the Secretary of HHS designated the National Quality Forum as the CBE, and in 2012, HHS awarded a contract to NQF to synthesize evidence and convene key stakeholders to make recommendations to HHS on a national strategy and priorities for healthcare performance measurement in all settings. Under that contract, NQF was also tasked with convening, among many other tasks, worked with in convening a multi-stakeholder committee to produce recommendations to HHS for performance measurement in home and community-based services that support community living quality. Next slide. This was a 2-year project that involved the development of a standard HCBS definition, the creation of a conceptual framework for HCBS measurement, including domains and subdomains of development, and also characteristics of high-quality HCBS, which you will see later on in my slides. It also required NQF to produce an environmental scan of existing measures and instruments. Next slide. That then created an opportunity or a platform for identifying gaps in HCBS quality measurement as well as promising measures. And lastly, the project also produced recommendations from the Committee for Prioritization in HCBS Measurement. Next slide. So how was that project done? One of the first things that NQF did was form a multi-stakeholder committee consisting of 22 national experts on HCBS quality. Something unique to this project was the active participation of a federal advisory group from HHS to help advise NQF throughout the project. When the committee was formed, NQF held committee in-person and web meetings, which were open to the public. It also facilitated workgroup calls and conducted online surveys to solicit the committee's input. 4 reports were published under this project. 3 were interim reports, and 1 was a final report, which was released last year in September. NQF had taken public comments on all of these reports. Next slide. In the final report, you will find the committee's definition of home and community-based services. The term home and community-based services refers to an array of services and supports delivered in the home or other integrated community setting that promote the independence, health and well-being, self-determination, and community inclusion of a person of any age who has significant long-term physical, cognitive, sensory, and/or behavioral health needs. You will find this definition on page 9 in the final report. Next slide. Stemming from the process of creating an operational definition of HCBS, the committee identified specific characteristics of a high-quality HCBS system. The committee felt that this was a necessary activity because the operational definition, as you just saw previously, is more functional than aspirational. So the committee wanted to also communicate its vision for what HCBS should be. Through extensive discussion, the committee established that high-quality HCBS should be delivered in a way that provides for a person-driven system that optimizes individual choice and control, promotes social connectedness and inclusion, includes flexible range of services that are provided in a setting of the person's choosing. Next slide. Integrates healthcare and social services to promote well-being. It promotes privacy, dignity, respect, and independence, freedom from abuse, neglect, exploitation, coercion, and restraint, and other human and legal rights. It also ensures balance of personal safety and dignity of risk, and supplies and supports an appropriately skilled workforce that is stable and adequate to meet demand. Next slide. It also supports family caregivers. It engages individuals who use HCBS in the design, implementation, and evaluation of the system. Reduces disparities by offering services that are provided in a culturally sensitive and linguistically appropriate manner. Coordinates and integrates resources to best meet the needs of the person. Next slide. It delivers accessible, affordable, and cost-effective services. It supplies data to all stakeholders. And finally, fosters accountability through measurement and reporting of quality of care and outcomes. Next slide. The other things that the committee developed was an illustration, as you see here, of the conceptual framework to show how performance measurement should work in HCBS. Each circle in the framework represents a level at which measurement can be applied. So you'll see at the consumer level, which is at the bottom circle, it's the level of the person receiving HCBS. There's also the provider level, which is the level of service provision, and then also at the systems level. Measurement at each of these levels of analysis serves different purposes and responds to different information needs. You'll see a list, I'm not sure if you can see it, but in the circle at the center of the diagram, there are 11 domains of measurement that the committee compiled. This illustrates the circle in the middle illustrates the overlapping levels because measurement can be applied at multiple levels within many domains. The continuous arrows surrounding the 4 circles indicate the transfer of information that's necessary to operate a dynamic learning system and the feedback loops between measurement and improvement efforts. Next slide. As I mentioned in the previous slide, the committee developed and defined the 11 domains and more detailed subdomains, 40 in all, for quality measurement in HCBS. The goals of constructing the domains and subdomains are to stimulate evidence-based research in support of quality measure development, to guide quality improvement efforts, and also highlight the important areas for measure development. Next slide. Through its deliberations, the committee identified gaps in measurement within all the domains and subdomains and discussed the barriers and challenges to measuring HCBS quality. These barriers and challenges include the lack of standardized measures across the country, the lack of or limited access to timely data on HCBS programs, the variability across the numerous federal, state, local, and privately funded programs with respect to reporting requirements, and the added administrative burden of data collection, management, reporting, and incorporation into quality improvement activities. Again, if you would like to learn more about the committee's work on this, please do look for the final report that's on the National Quality Forum's website, and I will provide you with more information on the resources slide later on. So finally, the committee also developed global recommendations that apply broadly to HCBS quality measurement. Its recommendations are support quality measurement across all domains and subdomains, build upon existing quality measure efforts, develop and implement a standardized approach to data collection, storage, analysis, and reporting, ensure that emerging technology standards development and implementation are structured to facilitate quality measurement, to triangulate assessment of HCBS quality using an appropriate balance of measure types and units of analysis, and develop a core set of standard measures for use across the HCBS system, along with a menu of supplemental measures that can be tailored based on the population, the setting, and the program. And finally, the committee recommended that we convene a standing panel of HCBS experts to continue to evaluate and approve candidate measures. Next slide. And here's a slide with links to the reports and other materials produced by the National Quality Forum under this project. This concludes my portion of the presentation. Thank you, Meredith. I'm turning it back to you.
Thank you, Eliza. We will now hear from Sean Terrell, who manages our contract work with the National Core Indicators in Survey Development.
Thank you. Okay, yes, Sean Terrell here, and you can advance to the next slide. We have a task order contract with an organization, the HSRI, Human Services Research Institute, and a few collaborators, which we'll go into in a little bit, to develop HCBS quality measures from the National Core Indicators for Intellectual and Developmental Disabilities and the National Core Indicators for Aging and Physical Disabilities. This is really our first, for ACL, our first attempt to try to build off of the work done by NQF and to start to build a set of measures that meet criteria and are endorsed ultimately by NQF for use in a variety of programs, frankly, and that can be, meet the robust standards that NQF sets for measure endorsement for things like value-based purchasing and other kinds of quality measurement efforts that are really designed around pay-for-performance kinds of models. For that reason, measures have to be quite rigorous and highly developed and pretty much unassailable. You can go so before we go to the next slide. So these are two sets of survey instruments which have their own history. I'll be talking about those. For the National Core Indicators, you go to the next slide, please. For the National Core Indicators, they focus on adults with intellectual developmental disabilities who receive at least one service in addition to case management from state IDD systems. Most of those systems, most of the people are in some sort of a home duty-based services waiver under CMS. This has been in development and, it's been operational now for quite a number of years, started in 1997. There are 3 surveys in the suite of surveys that are offered. One is the Adult Consumer Survey, another one for the family members, and another for staff stability. It is now operational in 46 states plus the District of Columbia, and it's funded by state membership fees, and ACL has supported expansion across states for a number of years. Next slide, please. For the NCI for aging and disabilities, older adults and adults with physical disabilities. And this is a much broader array of service programs: skilled nursing facilities, Medicaid waivers, Medicaid state plan, other state-funded programs, Older Americans Act programs, so programs that are funded through Administration for Community Living, PACE, which is a program for all-inclusive care for the elderly, programs that's a Medicaid, Medicare combined program, and managed long-term services and supports. It's really a full gamut of people there, and for that reason, it's a little more complex for the development process for this. They started this in 2012. They have it's one survey. It's adults in person only, and there's on the website for NAJWID's website. There's a 3-state report published. They're getting ready to publish a larger report. I think with 6 states that should be out pretty soon, and we're looking at about 20 states for 2017-2018 survey year. So it's growing rapidly. I think, if the states are interested in these surveys, they've been highly successful. Again, 46 states for the IDD, and this one's growing at a pretty high rate. Next slide, please. Here's the coverage for these two. The green is participating in both NCI and NCI-AD, and the sort of blue is participating in the NCI only, and there's 4 states that aren't participating in either of those efforts. So we should see the map turning green over the next couple of years, more and more green. Okay, thanks. Next slide. So here's the indicators. There's a great deal of overlap in these indicators across these two sets of instruments. The NCI-AD was derived basically out of, the NCI for intellectual developmental disabilities. There's a few different points. I think one says community inclusion, the other says community participation. I think those basically mean the same thing: self-determination versus an IDD versus self-direction and aging disabilities. Self-determination was the old term for self-direction. I don't think it's old in some places, but it's mostly people think of it in self-direction, so there's overlap there. Then there's a few extra sort of additional indicators within the aging disability around everyday living and affordability, future planning, and control. But in general, they're quite consistent with each other. Next slide. So we have a contract with the Human Services Research Institute with NASDS, which is the National Association for Directors of National Association for State Directors of Developmental Disability Services, and NAJWID is the National Association on States United for Aging and Disabilities. And so they're collaborators in this project. Their role and goal in there is a number of things we're doing in this contract. First, refine and expand the use of NCI and NCI-AD. So one of the things we want to make sure, one of the things that NQF requires, and what I think the field should ask for generally, is anytime we see results, we want to know, are these results valid and reliable? Can I rely, if I see a graph about something from a survey, can I rely on those results to be telling the truth, to be that the data is actually really good and accurate and was developed according to generally accepted standards for these kinds of surveys? And that can I review the literature on that? Can I go somewhere and find the report itself that shows that these surveys were developed and that this information, these data are accurate, based again on standard protocols, if you will. So what we've asked this group to do is to do whatever is necessary to do the psychometric testing around reliability and validity, to articulate clearly the sampling procedures, because these are based on state samples of around 400 people, and they're in the respective tools. Interview protocols, making sure that people doing these in-person interviews are trained, are delivering the interview as intended, and that they are implemented, these tools, with consistency across all the states, and to publish all of it in journals and peer-reviewed journals so everybody can see them and feel confident that these that everything's done really well. And then that's one area. The next area is also because we don't have a lot of questions in there that relate specifically to person-centered planning, yet we know that person-centered planning, thinking planning practices are kind of key. They underlie all of the work we do, and the basic concept of home community-based services is premised on each person having control.
Hi, I think we had some technical difficulty with Sean. Amanda, if you could go ahead and speak regarding the Rehabilitation Research Training Center at the University of Minnesota. We'd appreciate it.
Sure, I'd be happy to. If you could just advance the slide. There you go. Hi, I'm Amanda Riekert, and I am at the National Institute on Disability, Independent Living, and Rehabilitation Research, known as NIDLR, within ACL. And I'm going to talk about one project that's been mentioned a couple of times today, the Research and Training Center on Outcomes Measurement for Home and Community-Based Services. In 2015, NIDLR held a grant competition for a Research and Rehabilitation and Training Center on the quality of HCBS. And that I'll shorten that to the RRTC, just because it's easier to say than Rehabilitation, Research, and Training Center. But the University of Minnesota was awarded the grant for $875,000 per year for 5 years. And as I mentioned, this is named the Research and Training Center on Outcomes Measurement for HCBS. Next slide, please. The University of Minnesota staff are using this grant to develop HCBS quality measures. And these measures of HCBS outcomes quality will be applicable across a wide range of disability subgroups and the aging populations that receive HCBS. The grantee team at the University of Minnesota includes partners and organizations that have relevant expertise that is specific to these disability subgroups and the aging population that are covered by the measures. And these partners include several universities, the National Council on Aging, and relevant policy and research organizations. Next slide, please. The work of the University of Minnesota is in response to the NIDLR and ACL priorities. And these priorities are the following. One is to identify or develop measures and then test the reliability and validity and usability of those measures in assessing person-centered outcomes of individuals with disabilities who receive HCBS. Another priority is to work closely with NIDLR, ACL, and the National Quality Forum, or NQF project, on HCBS quality. Third is to develop procedures and mechanisms for applying these outcome measures in policy and service delivery settings in an effort to maximize the quality and appropriateness of HCBS from the end user perspective. Fourth is to collaborate with stakeholder groups in developing, evaluating, or implementing strategies that increase the utilization of these new HCBS outcome measures. And finally is that they will serve as a national resource center related to person-centered measurement for HCBS outcomes. Next slide, please. As a starting point, the University of Minnesota founded their work on the NQF that Eliza described a little bit earlier, and she even posted these 11 domains. So this framework focuses on consumer leadership and system development, system performance and accountability, equity, service delivery and effectiveness, person-centered service planning and coordination, caregiver support, workforce, holistic health and functioning, community inclusion, human and legal rights, and choice and control. Next slide, please. The grant at the University of Minnesota includes 6 main studies. The first study uses a participatory planning and decision-making process with people with disabilities, their family members and providers, and program administrators. And this is across 5 disability groups, including people with IDD or intellectual and developmental disabilities, physical disabilities, traumatic brain injury, mental illness, and the aging population. The second study involves a gap analysis between what's included in the HCBS domains and subdomains and existing measures. And this study will attempt to identify measurement gaps through an analysis of what's currently available, what instruments are currently available that focus on outcomes associated with HCBS and the NQF's outcome measurement framework. And studies 1 and 2 are almost complete, and we'll have more information about that soon. Study 3 will involve identifying high-quality and high-fidelity implementation practices for various HCBS outcome measurement programs. Study 4 will refine and develop the HCBS outcome measures, and these will be this refinement will be based on the results from studies 1 through 3 to fill in those gaps in measurement that were identified. Study 5 will test the reliability, validity, and sensitivity of these new measures and the measures that were changed by using a large-scale testing of the most critical measurement constructs. And finally, Study 6 will involve identifying and testing risk adjusters to increase the validity of the measure estimates. And similar to Eliza, this is another project that we'll be presenting in a future webinar. So we hope you'll be sure to tune in for much greater detail about these projects and the results that they're finding later this year. Thank you, Meredith.
Thank you, Amanda. We have Sean back on again, and he'd like to say a couple more statements. Sean?
Okay, thanks. You can go. So on the just to finish up on person-centered planning, I apologize. There was a phone got cut off. So they're going to revise and they're going to develop some questions around person-centered planning to either insert into the existing surveys, or they might even create a different survey depending on how many questions in there we feel we need to have, and they're sort of currently working through some focus groups with people who use services and supports and others to help develop those questions. One more slide, I believe. And yes, and so actually this is fine because this fits right into what Amanda was talking about. Part of the work here is that we want to have some measures that are endorsed by NQF, to put home and community-based service measurement into the same arena as those that are more medically oriented. So there's over 600 measures now that have been endorsed by NQF around the medical field, the medical services, and they get regularly inserted into a variety of CMS programs, for instance, managed care programs, programs that integrate medical and long-term services and supports. So those are out there, and they're used, and they have a long track record. In fact, they have a little bit of a challenge now is aligning all those measures, because there's 600 measures, and many of them are very similar, and so they're doing a lot of work on that. On the other hand, on HCBS, we really don't have many measures, as we've talked about, yet we're running into a situation where we have home community-based services and a full array of Medicaid services, for instance, offered by the same plan, but the only thing that really has those value-based measures, value-based purchasing measures on the medical side. We want to have HCBS measures to be as prominent and as those other measures are for the purposes of HCBS, so we don't lose people, so we don't lose this concept in this more integrated world that we're entering into. So that's the purpose. We want to get 20 measures minimally out of the NCI suite, NCI and NCI-AD, and we think that this is a good setup a good place to start because the states already have the infrastructure. They're already 46 states for NCI already have state, commitments and ongoing work to administer these surveys. And so the measures, the numerator, denominator kinds of measures that Susan was talking about, it's an easier fit because they already are doing, asking these questions. So we think that this is a good place to start for us in coordination with everybody else who's doing measure development, particularly the work that Amanda was just talking about at the University of Minnesota, so that we don't have the overlap and the sort of competing measures of the same thing that we see now in the medical field. And then the last thing that we are asking, that they continue to do, is the technical assistance around how to do all this work, how to administer these surveys, and et cetera. So that's, I think, it for me. And thanks for coming back to this slide. I think it was relatively important for this topic. Oh, by the way, I'll say one more thing. This is a precursor. So the folks, HSRI and their team will be doing, I believe, their own webinar in the not-too-distant future with a much, more detailed look at what they're doing. Stay tuned for that.
Thank you, Sean, and thank you to Amanda and all of our speakers. We greatly value your commitment to the important work of HCBS Quality at ACL. We will now move into the Q&A portion of our webinar. Because of time limitations, the opportunity to submit questions was provided to those who registered previously. The question, how do you measure quality, was selected from these submissions. Ultimately, the goal for measuring quality is to help guide decision-making and drive improvement over time. Unless we measure, it is difficult to know exactly what we need to improve and whether we have, in fact, achieved improvement. In order to begin to measure quality, we need to know what data we should be measuring, and we need to ensure that that data is reliable. This is a fundamental component that supports and advances quality improvement efforts. We can measure quality in many different ways. At HHS, there are a number of efforts that support quality measurement, including what you heard from us today about the 3 initiatives that ACL is spearheading. Also, the Substance Abuse and Mental Health Services Administration, also known as SAMHSA, has a behavioral health quality framework and has identified several National Quality Forum endorsed measures under 3 of the goals: person-centered care, healthy living for communities, and reduced costs of behavioral health care. The Centers for Medicare and Medicaid Services, or of course CMS, requires NQF-endorsed measures in many of its funding authorities, including managed care waivers, 1115 demonstrations, and dual-eligible programs. For HCBS waiver programs, states are expected to develop a quality improvement plan and measure 6 assurances, which are administrative oversight, level of care, qualified providers, service plan, health and welfare, and financial accountability. Lastly, the Testing Experience and Functional Tools program recently received endorsement for 19 HCBS measures related to the experience of care in HCBS programs. And with that, we hope this webinar was helpful and informative. Thank you for participating. The slides will be emailed to all who RSVP'd, and the slides and transcripts will also be posted to acl.gov. As Edwin mentioned, we need you to help us continue this work and look to you for input, assistance, and collaboration on all things HCBS quality. Our next webinar will be on June 28th and will expand on Eliza's overview of quality framework development. As Eliza mentioned, representatives from the National Quality Forum and the SCAN Foundation will discuss the progress made in quality framework development. An announcement will be sent out in early June with registration instructions. Thank you.
Thank you. This concludes
the webinar.
Thank you. This concludes today's conference. You may all disconnect at this time.